that are happening in the field, and each particular individual with a specific cancer with a different genetic makeup fits into a different treatment algorithm. And probably human intelligence cannot keep pace with this, and you need machines and machine learning algorithms and forests to tell you where exactly you need to be. What exactly is this concept of artificial intelligence? Most of you would have heard about it by now. It's going to be the future of medicine, more so in intensive care. It, it's not only in healthcare, manufacturing of cars, for example, manufacturing of drugs, for example, is heavily depending on artificial intelligence for performing tasks which probably will require human intelligence, but with lot of variation, errors are likely to happen. They are simulated to mimic human intelligence and behavior, such as learning, reasoning, problem solving, and decision making. So they can actually give you a solution and give you a suggestion on how your treatment plan should actually be progressing. That is about artificial intelligence. What is maturity model? If you take an analogy to electronic medical records, for example, when electronic medical records first came into this country about 15 years ago, and several big hospitals started implementing them, there was a hesitation, there was a resistance, and an unknown fear that patient data could be compromised. So you needed to have people buy into that concept that electronic medical records are probably safer and are probably more robust than physical record. This is something very similar. This maturity framework is used to assess and evaluate the level of maturity of a particular process or area within an organization. How well the organization buys into the concept of artificial intelligence. And also, it depends upon the person who is practicing that artificial intelligence to convince the organization that this is the way to go in terms of patient care. They will probably help you to identify the level of maturity, understand the steps which require to understand these processes. Why do you need artificial intelligence? The reason is healthcare is just illnesses are just going out of hand all over the world, and the spending on healthcare is reaching about 20 trillion US dollars in about 5 years or 15 years from now. But as the diseases are increasing, novelty of diseases are increasing, our understanding of phenotypes of diseases is increasing, the number of healthcare workers who are able to keep pace with these advances in healthcare is not keeping pace. So we will fall short everywhere, not only in the resource limited countries, even in the well to do countries will um, face this problem. So we need to have systems, and COVID actually told us that if something like that happens, every healthcare system in the world will collapse. The Italian system was supposed to be the second best healthcare system in the world. It collapsed. It collapsed. Whereas a system like ours, which depended more on multi-purpose health workers, the Anganwadi workers, the village healthcare system, we did reasonably better in spreading the message of vaccine than our other countries in the world. So this is going to happen sooner or later. So the top five areas where artificial intelligence is going to play a big role in the next 5 to 10 years, as we see it, is targeting public health, bringing some problems from the public domain and doing preclinical research, develop clinical care pathways, and give patient facing solutions. I'll give you a simple example. You have a patient who's got a traumatic a road traffic accident, for example. He's got a traumatic brain injury. He's got lung contusion ARDS. He's got a perforated bowel, intra-abdominal hypertension, and multiple fractures with rhabdomyolysis, AKI. If I want to treat this patient, there will be 8 or 10 guidelines which are available for each specific disease. You have guidelines for TBI, you have guidelines for AKI, you have guidelines for ARDS, you have guidelines for intra-abdominal hypertension. Now, this patient will have an intersection of guidelines where some aspects of the guidelines are applicable to this patient, some of them are not applicable to this patient. So you standing at the bedside of the patient in your morning round have to take a call which part of the guidelines you need to bring in for this patient, which part of the guideline you cannot bring in for this particular patient, like a PEEP with his ICP or his intra-abdominal pressure versus his CVP. How do you do it? So to bring that, if you can have a machine learning platform which will put all these guidelines along with this particular patient's clinical condition, it will pick out those things which are not to be used to this patient. It will show on your screen that these are the parts of the guidelines which this is the treatment algorithm for this patient, and these are the do not do's for this particular patient. And if you by mistake actually write one of those interventions, it will actually highlight saying you are following a wrong part of the algorithm. So just because your patient does not come into a standard set of guidelines, we cannot deny treatment, and that's where it will help you to optimize your healthcare operations. So the six areas where you need to work on, where the stakeholders operate, which will make this an integral part of our healthcare ecosystem, are the people and the workforce. They need to understand what AI actually is. You need to understand what data and its technology utilization is. But for all this, you need to have a regulatory governance. The people who run the hospital, they should understand that AI is the way to go for high quality, safe patient care, which will help them to design the processes and will keep the multiple stakeholders in the loop. But whatever you do, any such model will succeed if it can give you a successful business model. For example, when I was trying to get ECMO machine into my hospital 14 years ago, 16 years ago, it was very expensive. It had to be imported from somewhere. And when I made a case for the CFO, he said, "How much revenue will you generate on that?" So if I was unable to give him that financial model, a business model, we were the first ECMO center in the whole of Andhra and Telangana in those days during the H1N1 pandemic epidemic. So we could say that we will be the first ECMO center. These are the patients who will come. This makes economic sense. This makes business sense. Then the organization will buy into the concept of whatever you are proposing. So let's look at how you can get the people and workforce to buy into this concept of artificial intelligence. It will strengthen your national capabilities. I'll give you another example. You have dengue, for example. I'm sure if you look at the Southeast Asian countries, there will be a million dengue patients that are generated every year. If you can put the data points of all these million patients into a algorithm and identify how to pick up the ones who will deteriorate faster, who will require advanced treatment, who are the ones who require extracorporeal support, can be easily picked up. This will actually improve the quality of care which we are giving to these patients, and it will inculcate that appropriate change management. And this will be a human centric design. So you get three patients with dengue, not all of them will behave in the same way, and you can't rely on a western algorithm to tell you how to manage dengue, malaria, leptospira, scrub typhus. We are the epicenter, and we are the brains of intelligence, of artificial intelligence. We have the financial and we have the technical know-how on how to develop these algorithms because of our training systems in this part of the world. So we should be taking the lead. When you look at data and technology, we should just as I said, we should define goals. What are your goals? I want to look at lung cancer, for example, which is uh, common in this country. Cervical cancer, for example. I need to put in my goals like dengue, tuberculosis, drug resistant tuberculosis, and identify the data sets which I have to capture so that we collect, we co-create, and we implement authoritative standards which will be the benchmarks for the rest of the world, which will also help the government to draft legislations. If this is the particular problem, this algorithm has to be applied. It becomes a part of the national guideline or the national policy, then everybody will follow. It's like Australia. If a trauma patient goes to any ICU across Australia and New Zealand, the kind of treatment they get is exactly the same. The protocol for ICP management is exactly the same. The protocol for hyperkalemia management is exactly the same. The same culture has to come into this country where heterogeneous treatment is the norm. If we can stop it, we'll have done a fantastic job. And AI and data mining is the way to go about doing it. That brings us to how governance and regulations can do it. We need to actually have integrate the fundamental rights, regulatory restrictions, patient safety, for example, your HICPAC compliances, for example, and legislation should give some mandate that these diseases or these algorithms should be driven by data science. Then people will buy into this concept. we should assess the needs and opportunities for implementing these solutions. I gave you so many examples. There are innumerable. I'm working on AKI. I will give you another example how it helps you to design and structure a process. I'm developing an AI platform for acute kidney injury. We all know that hypovolemia, hypotension, contrast exposure are risk factors for AKI. If I tell you that hypoxia at ER admission, an a PaO2 of less than 70 in the ER is a strong predictor for AKI during the patient's stay in the hospital, irrespective of his hemodynamics. How many of you would believe it? But it's a fact. It's a fact. So we would be missing quite a few of these pneumonia patients who come hypoxic, hemodynamically stable, who go on to develop AKI and then end up on RRT. You could pick them up in the ER by application of simple data points which are acquired by your monitors at the bedside. For this, you need to have a champion who will have a key performance indicator and he will scale the mandate as the situation evolves. That is the stakeholders. Who are the stakeholders? From my perspective, the biggest stakeholder is the patient, but they can't understand what AI and machine learning is. So the next biggest stakeholder is the professional, which is us. We should understand that if I negate heterogeneity and individualize my decision making process, my patient will get better faster. If we can understand that, we become a stakeholder in AI maturity. Of course, nothing works, as I said, without a business model being developed, a business model being presented to the authorities, to the government, to the organizations. So we should create, simplify, and promote incentive structures for AI solutions. A unit, a hospital, a society, a, a government setup which is working on AI-based technology should be given incentives for working, for rationalizing its resources, and giving more manpower to execute some of the things which the AI algorithms will throw up. So there are several stages. So this is a big complex scenario. So there are stages to the maturity which a system can develop or acquire in terms of implementing maturity. That is, how mature is the system in accepting a new intervention. As I said about electronic medical record. Today in India, 23.4% of hospitals are working on EMR. Still low, but compared to what it was 10 years ago, it's very high. And the accreditation agencies, be it NABH, be it JCI, are accepting your electronic signatures as valid. The court of law accepts electronic signatures as valid. The ICMR have set guidelines for electronic medical records. So it's going in the right direction, which is the direction where AI will go in the near future. We are somewhere at the first point, somewhere here at awareness. At this point, in critical care, we are at awareness level. We know that AI is going to work. AI is a concept, but we need to bring it into active AI, where there is an AI experimentation, like what I am trying to do on AKI. So it is a data science collection and implementation, which will then become operational, where the AI is useful in production. But one unit, one individual, one disease does not make a difference. It has to become a systemic culture. Everybody who is treating such patients across the country, across the world, has to buy into this concept. That is systemic maturity. Lastly, what happens is transformational change. That is, giving fluids in sepsis is become a transformational change. Everybody gives. Everybody does not, you don't think, should I give fluids to a septic shock patient? So should I use AI in my critical ill patient? The answer is yes. That is transformational. Maybe 20 years from now, every unit in this country will be running on AI-based systems. So if you're looking at awareness, it is early AI interest with the risk of overhyping, like what some of you may be thinking I'm doing, but it's not so. Active is experimentation, operational in production, and systemic is pervasively used for digital process transformation. There's no choice. Some of the hospitals have stopped printing letterheads in their hospitals to promote the use of electronic medical record. You can't write a prescription. You can't write something on a paper and give it to somebody. It has to be on electronic. So if you go to that systemic level, getting it into a transformational stage where it's part of the business DNA of the organization and the system and the healthcare system becomes much easier. So to summarize, AI is a definite entity to reckon with in healthcare. Critical care is probably the area because a lot of heterogeneity in treatments, a lot of intermingling of specialties and organ system dysfunctions will happen. It will be a necessity very soon, and the sooner we learn this and accept it, the more informed and the more safer we will be. We should see artificial intelligence as an ally, as a colleague, rather than somebody who's going to take away your job. It's not your rival. It is an ally. It's a friend. It's a contemporary. It's a colleague. If you start seeing that, you will buy into it faster. Therefore, AI maturity is the key to utilize its true potential, and we should be able to understand its strengths. It will have inherent weaknesses. We need to overcome those weaknesses. Thank you. I don't know whether there will be any questions, but I'm happy to face.
Dr. Samadhi.
Maybe this is working.
Thank you, Dr. Samadhi. I like a quote by Victor Hugo that says he cannot stop an idea whose time has come, and time of AI is right here. And like whenever you get chance, you should try to learn it. And it is always good to learn AI from a doctor as well as data scientist, than learning from a pure data scientist. And the sir has told about the maturity process, and I think, and it will take almost 20 years for the transformation. I think it will come quicker than it, because it is going in a very tremendous way. I would like to know from you how AI can help us to do RCTs. Like doing RCT is now a very tedious job. We need to take consent, we need to go regulation and all. Can it help us to do some,
So,
trials?
yeah, that's again something very interesting actually. Currently, currently, the gold standard, I don't know whether gold is the real gold standard for precious metals anymore, but people still say gold standards. I am also using the word gold standard. Maybe I should use platinum standard, I don't know. So, RCTs and therefore meta-analysis are the gold standard for evidence-based medicine as of at this point of time. They are the apex of the evidence-based medicine pyramid. But the inherent problem with this RCTs and meta-analysis is that it it all assumes that the hypothetical question you are asking is correct. So an RCT is based on, I have chosen this condition, is my intervention correct or wrong? Or is my treatment correct or wrong? Whether that treatment actually should be used for that condition, nobody asks. So, and for a meta-analysis, the problem with the meta-analysis is if you have 10 randomized control trials, one has 10,000 patients and all the other 9 have about 300, 400 patients, the results of a meta-analysis will be swung by the 10,000 study, 10,000 sample size RCT. There are inherent problems with the RCT. So where AI can, as I said, correcting hypoxia can prevent ICU acquired AKI. That's a hypothetical question. That doesn't come with the routine approach with an RCT, because they will say, is contrast a risk factor? Is there an entity called contrast associated acute kidney injury? So the way machine learning can help you, the way data science can help you in designing more pragmatic, more useful randomized control trials is to help you to ask the more relevant questions to to form more relevant hypotheses. Right now, we are, for example, we are talking about balanced crystalloids versus 0.9% saline and its effect on AKI. Is that the right question to ask? Is it only AKI that's going to happen? That AKI may be a consequence of an effect of these fluids on the glycocalyx. So that information only a data, if you analyze a million or 10 million data points, you will get such exotic hypothesis. So RCTs, if they are guided by a machine learning platform and data analysis, they will probably ask more relevant questions than what they are doing at this point of time.
Yash has a question.
Radiologists who are not trained in will be replaced by AI. The speaker said no, radiologists will not be replaced by AI, but radiologists who are not by practice, those who are
Yes.
practicing AI. So we have
Yeah, yeah, yeah. So it's not, see, it's not even pathologists are worried, right? The pathologists are worried that AI will replace them in interpretation of neoplastic disease. It's not going to happen. What AI is going to tell you is that to warn you what you are missing. For example, I'm looking at images of a subarachnoid hemorrhage. I'm looking at conventional manifestations of subarachnoid hemorrhage. But if I put 10 million CT scans of unreported patients into a system, and then it picks up certain findings which are subsequently consistent with subarachnoid hemorrhage, which may not be the conventional accepted presentations, it will warn the radiologist that this pattern, this presentation fits into a probable diagnosis of subarachnoid. Please proceed further for more detailed investigation. So it will actually make patient care safer, and we all like to treat shock. We all try to want to treat hypoxia, but why not prevent it? You need to ask that question.
Just adding on a comment along with Dr. what Yash has to say, that I think in the near coming future, AI going to, looking at
Yeah, so definitely, I think 10 years from now, MBBS, one of the papers in MBBS after anatomy, physiology, biochemistry, social and preventive medicine, we used to have something called biostatistics in our exams. That will be replaced by data science and machine learning. That will be it will be a part of our curriculum. It has to be, otherwise we'll be left behind in the race. The NHS is actually training its consultants in data science. The Australian healthcare system is training its doctors in healthcare. So I'm sure from ISCCM we will take initiatives. We will train our people in using these platforms, and it is a continuum. It's not going to be one off. I do one talk or one symposium or one workshop. You can't learn machine learning or data science in that. But as I said, it is your ally, it's your friend, it's your colleague on whom shoulder you can put a hand and walk together. It's not a friend who or an enemy whom you need to box out of the ring and win the match. It's not that bad.
So yeah, there's no doubt that AI is a way forward. But what do you think could be potential problems of AI for the future, or pitfalls, or something exclusive to the technology, not things like medico legal and
Medico legally, it will be just like EMR has now
Technology.
become legal. EMR has now become legal in this country. AI also will become legal very soon. But as you said, what are the problems? The problem is it may throw up irrelevant correlations, right? For example, if you take 1 million patients who have had ischemic stroke, it may show that driving a Mercedes is associated with ischemic stroke. How does it matter, right? That should not stop you from buying a Mercedes if you can and you have the passion to drive such a car, isn't it? So it may throw up unnecessary correlations, but from a medical perspective, it may result in over investigation of some patients. The risk is about 20% of patients who are investigated based at this point of time, 20% of patients who are investigated based on artificial intelligence based decision making trees and forests are investigated unnecessarily. But what about the remaining 80%? If you look at it from that perspective, it's a small price to pay in a government funded healthcare setup. But in a privately funded healthcare setup like that, you are likely to over investigate, and it is likely. But that comes with maturity. As a period of time, you learn from this, and then you say, this is not the pattern, so let us change. So it is a dynamic thing. It can't be fixed in a, for example, surviving sepsis campaign. How many of the recommendations are based on high quality of evidence? But we still follow, like the Bible, we stick them on walls, we show NABH that I'm following surviving sepsis campaign, right? So it can't be like, and every guideline comes every 3 years, whereas this one is instant feedback. And the beauty about artificial intelligence, it is real-time audit. See, good units across the country have a introspection. They see how many of my patients who got extubated got reintubated, how many got readmitted, how many had unexpected deterioration. A few quality markers. Now, what is that going to do? It is going to help the next set of 100 patients who are going to come into your hospital, into your ICU. What about the fellows who have died? So the artificial intelligence, as I said, if I have a patient who has chronic liver disease, has bled into his brain, and also has got compartment syndrome, 3 different guidelines are intersecting, and I'm writing some treatment. The AI will show an instant audit. This is not the right treatment for this patient. Please correct your prescription. So that particular patient also benefits. So that is the difference between retrospective audits, which we are now doing, versus concurrent stat audit, which the AI platform will give you. It won't pick up one. What I'm saying is, an ML forest will have different trees. The tree will have different branches. Each branch will have it will be populated by different aspects for the guidelines for example, as I said, the trauma patient. There will be the BTF guideline. There will be the ARDSNet guideline. There will be the intra-abdominal, the abdominal compartment syndrome society guideline. It will take all the data points of this patient, his intra-abdominal pressure, his plateau pressure, his ICP, his heart rate, his stroke volume variation. Then it will pick up one aspect of this guideline which is applicable to this particular patient, right? And it will also tell you which aspects of these 4 guidelines are not applicable to this patient. And when you write something which is falling into those unapplicable guideline, it will highlight saying it is not safe for this patient. It's up to you to override it, but it will warn you. It will warn you that this set of guidelines for this patient is not correct. For example, I want to measure, say, I want to measure IVC diameter in somebody with abdominal compartment syndrome. It will highlight and say this is not the test to be done with somebody with raised IAP. You want to override it, it's your choice, but it will warn you. Please don't do this. What bias? How will it be a bias? No. So the bias comes when you're, again, as he asked, what is the difference between RCT and machine learning, right? The largest RCT in critical care had 36,000 patients enrolled, right? That is only 36,000 patients. Imagine 50 million patient data points from across the world, which has been imagined. Would it not cut your bias down to that many more? No, it's easily, see, that's what I'm saying. If electronic medical record can give you the SpO2 value in this very country, I did a very focused study of acute kidney injury in hypoxic patients in 30 hospitals in my city. These hospitals were all using electronic medical record, right? I could get 60,000 data points in 14 days. 14 days. So does it not help me? So it actually cuts down the bias. But the bias is I am completely sold to AI at this point of time. So I will argue in favor, right? Until somebody stands up and says this is bullshit. That's going to take time.
Yeah, thank you. I think that was